This video demonstrates the percutaneous tunnelized implantation technique for the insertion of the MedComp split stream catheter for long-term vascular access for hemodialysis and apheresis. The MedComp kit comes complete with the necessary components for catheterization, including one split stream catheter with polyester anchoring material, one introducer needle, one tearaway sheath dilator introducer, one J-flex guide wire, one threaded trocar with tunneling sleeve, two Lock-Right adapters with Roberts clamps, two injection caps, one number 11 scalpel, 2/0 silk suture, and adhesive wound dressing. Additionally, the operating room should be supplied with one pair of scissors, forceps, needles dish, syringes, and gauzes. The patient is placed in a modified Trendelenburg position with the head turned to the opposite side of where the jugular vein is to be cannulated. A rolled towel under the neck facilitates jugular vein access. Catheterization will be performed at the apex of a triangle formed between the two heads of the sternocleidoid mastoid muscle. The apex should be approximately 3 finger breadths above the clavicle. The patient is draped and local anesthetic is administered. Create a skin wheel taking care to infiltrate the subcutaneous tissue for 2 to 3 centimeters. Next, fill the one-step bulb with saline. Once the bulb is fully primed with no air present, squeeze the bulb with thumb and forefinger. Continue to squeeze the bulb until the needle is under the patient's skin. Once the vein is located, blood will flash back into the flexible chamber. Once blood has been aspirated into the bulb, advance the J-flex guide wire past the needle hub and into the vein. The guide wire must pass without resistance into the exact position. Remove the needle, leaving the guide wire in place. The guide wire must rest at the junction of the superior vena cava and the right atrium. Confirm guide wire placement with fluoroscopy. Now, with the number 11 blade scalpel, make an incision at the site. If necessary, enlarge this area with forceps. Next, a sheath dilator is passed over the guide wire and into the vessel. Once the vein has been dilated, remove the dilator and guide wire, leaving the tearaway sheath in place, being careful to occlude the sheath opening. Split the arterial and venous lumens by grasping the distal ends and gently pull apart to the point printed. Do not split beyond this point. Splitting the lumens beyond this point may result in excess tunnel bleeding, infection, or damage. Now the catheter is fed through the sheath until the tip is positioned correctly in the target vein. Remove the tearaway sheath by slowly pulling the sheath out of the vessel while splitting the sheath by grasping the tabs and pulling them apart, being careful that the catheter does not back out of the vein. Air embolus is avoided by the Trendelenburg position and asking the patient to inhale deeply and hold their breath. At this point, fluoroscopy should be performed to confirm catheter placement. The tip of the venous catheter is just reaching the opening of the right atrium, and the tip of the arterial catheter is 4 centimeters higher. This positioning of the two tips prevents blood recirculation during hemodialysis. The tunneling process is initiated by the administration of sufficient anesthetic to the entire length of the tunnel's path. An incision is made at the exit site wide enough to accommodate the cuff, approximately 1 centimeter. Use blunt dissection to create the subcutaneous tunnel. Insert the tunneler into the insertion site and create a short subcutaneous tunnel. Tunnel in the direction of the tunnel exit site incision. Do not tunnel through muscle and be careful not to damage surrounding vessels. Attach the tunneler to the tunneler adapter at the priming end of the lumen. Lead the catheter into the tunnel gently and pull the catheter until the loop at the exit site is gone. Palpate this area to ensure there are no kinks and there is a smooth turn. The trocar is removed by cutting the catheter lumen squarely at the designated priming volume lines, and clamps are attached. The extension set is attached to the lumens by sliding the adapter over the lumen. Slide the compression ring toward the end of the catheter, then twist the adapter together. The extension set with Roberts clamp is utilized to preserve catheter integrity. Attach the suture wing hub to the lumens. Aspirate both catheters. Once adequate aspiration is achieved, both lumens should be irrigated with heparin-filled syringes using the quick bolus technique. Now close the extension clamps and attach injection caps. The small incision is closed with sutures. The patient is now ready for dialysis. The MedComp split stream offers numerous benefits to both the patient and the caregiver. The two single-lumen catheters dramatically improve flow rates compared to traditional plastic or permanent cannulas and allows blood flows of 400 to 450 milliliters per minute with acceptable venous resistance and long-term patency. The two free-floating lumens help eliminate catheter occlusion by the vein. The split stream is manufactured from soft radio-opaque polyurethane material, which provides increased patient comfort while providing excellent biocompatibility.